Hello, everybody. I'm Pam Garside. I'm chairing this session. I think I'm described as a friend of UCL Partners, and it's fantastic to see you all here today. It's marvellous, such a great group. And before we start, I want to profile you, because nobody's seen a delegate list. So how many of you, I won't say are real people, because we have 700 people sticking their hands up. How many are NHS? Okay, of that group, how many clinicians, clinical background? How many CCGs, CSUs? Okay, let's call it third sector, voluntary charitable sector. Okay, government, NHS England, admitting to it, very good. Private sector, hooray. Are the rest of you sort of confused? No? How about people, carers, patients? You put those in the same category as our marvellous, well, I'm a patient, people's panel. That's great. So we're going to talk about an ageing population and opportunity and what this means for long-term conditions. I'd like to first introduce Olivia Butterworth, who's going to introduce via her colleagues the people's panel.
Thanks very much. Is that on? Yes. So my name's Olivia Butterworth. I've got the best job title at NHS England. I'm Head of Public Voice. And that means what I want to try and spend my time doing is making sure other people have that voice. So we've deliberately renamed the People's Jury People's Panel, because we would like this to be about collaboration and working with and alongside people, as opposed to a bit of them and us. Nobody's standing in judgment, we're all in this together. So I'd just like to start by very briefly inviting my patient panel members, people panel members, got that wrong as well, to just say who they are. Is that okay to start with you, Ray? Looking slightly terrified.
I'm Ray Funnell. I've actually had a heart valve replacement and I'm now on long-term warfarin, so I'm self-testing and managing my own. So self-testing on that.
Thank you, Ray.
Hi, I'm Michael Sears. I'm a bowel transplant patient and involved in using digital media for patient engagement strategies.
And on Twitter a lot.
Hi, my name's Clive Bolch. I'm a diabetes sufferer and I've survived a stroke.
I'm Bonnie Green. I'm a cancer survivor and my husband is a cancer survivor.
Hi, I'm Sue Line. I'm a kidney transplant recipient and I'm a reciprocal carer for my husband, who's also a kidney transplant recipient.
My name is Jonathan Hope, and you know more than enough about me already.
Hi, I'm Lynn Craven and I live with MS and I'm as healthy as I possibly can be.
Joan Smith and I live with several long-term conditions.
Hi, I'm Sanjay Chadha. I've had multiple sclerosis for over 25 years and I promise I'm not always late.
But we are going to get in third gear.
Hi, I'm Penny Roberts. I'm a nurse who broke a neck and now I live with tetraplegia.
Thanks very much, Penny. Jeffrey.
I'm not really called Jeffrey, am I? My name's Mark Wilkinson. I'm a physiotherapist and I'm supporting Penny Roberts today.
Hi, I'm John Gessler. I live with a long-term condition and I'm a carer for somebody else with a long-term condition.
Hi, I'm Jill Ackroyd. I'm here today representing Arthritis Care, but I have several long-term health conditions. I'm also an elected governor, a patient governor for the Lancashire Teaching Hospitals and a tutor on the Expert Patient Programme.
Hi, I'm Angie Usher. I've got multiple long-term conditions and I'm also a carer for my aged parents who both have long-term conditions.
Thanks, Angie. They've got, if you don't mind me saying, a few hundred years of experience of long-term conditions between them. And we're going to talk more later about some of their reflections on today and some of the workshops. But now I just want to hand over to Anya, who volunteered or was volunteered to be the spokesperson for the panel. So she's just going to start by opening up some of the reflections we've had so far and I suppose our hopes and aspirations for where we want this day and tomorrow to go to.
Thank you. So, thank you very much. I'm Anya de Jong and I live with several neurological long-term health conditions, which I can't pronounce, so I won't. Like everyone else here, it's a privilege to be part of the Future of Health conference, but actually what's a real privilege is to be here working with all the people that you've just heard introduce themselves. I hope that the People's Panel can make a really positive contribution, not just to this conference and all the conversations that we're going to have over the next couple of days, but I hope that we can actually make a really positive contribution to daily life in the outpatients clinic and in the houses where people with long-term health conditions face all of these issues on a day-to-day basis. So over the next couple of days, I'd really like this People's Panel to embody the kind of partnership that everybody's talking about and that we so desperately want from all of our clinicians and healthcare professionals. So to clarify what's already been said today, we're not a jury. So we're not here to pass comments or verdicts. We're a panel, so we want to be in an open dialogue with you guys throughout the course of the next couple of days. And to reflect that, we want to try and break down some of the us and them barriers, partly because actually us as patients, and this is something that's come out of the conversation so far today, and comments from the panel, is that us and them doesn't really do justice to the fact that patients are not a homogenous group. We've already had disagreements between the patients panel on interpretations of what's been said today. So you can't just treat it as us as them, because professionals are very different, and so are we as patients. And we also want to work towards something where we're using a common language that you guys understand, because that's what we want in our day-to-day care. So without jargon, and when people say we want to try and work away from the word patients, to actually try and continue to use that in our language over the next couple of days, and say try to refer to us as people and not patients, because that's what we're asking of you, and so we're going to try and embody that ourselves. And although we're not a jury, we're not afraid to speak up, and I hope that you've been able to benefit from the really valuable contributions in the first workshops already today in terms of the point of view and the perspectives of everybody on the panel, and I hope that continues through the next couple of days. But also, this is the first time that we've had a People's Panel at any event I've been to. It's the first one I've been involved with. So we're going to be learning our way through this as well, and we want to be able to do that with you in the same way that learning about long-term health conditions, as people, we learn about it on a daily basis, and healthcare professionals and commissioners learn about it on a daily basis as well, and to try and amalgamate some of that learning. And to also respect some of the expertise that we all bring to the table, no matter how that expertise has been gained, in a sort of an equal way. So I may be an expert in my condition, but I don't have half the alphabet after my name. And I know there'll be other people in the room who are experts in specifics of neurology and have got half the alphabet after the name. And no matter how you've learned about neurology, whether it's through studying it or whether it's through living with a failing nervous system, actually both of those experiences should be valid. And then just to focus very briefly on what this conference is all about in terms of long-term health conditions. What I hope we can do over the next couple of days as the People's Panel is ground some of the rhetoric in the day-to-day experiences that we face. And a dear friend of mine called this walking through mud day in, day out. And so all the actions that you talk about are jobs for healthcare professionals and commissioners, but for us it's actually more than a job, and it's our whole entire life. So when people talk about building the house of care, we'd really like to start building that. We've talked about it quite a lot, and we're very keen to start working with you to actually put a lot of this into action so that we can have meaning and tangible differences in the clinics across the country. Because this is a wonderful environment to be in for 2 days, because you're meeting people who believe in all of this and are really passionate about it and want to see things change. But unfortunately, as patients, we're not always in this environment, and we are sometimes in clinics, outpatients, inpatients, any sort of healthcare setting where we're not having these kind of conversations, and we want these to be spread. And finally, it's just living with this every single day is a pretty big challenge, and actually we can't really afford not to get it right. And I have a blog called The Patient Patient, which is quite ironic, because I don't think we can particularly afford to be patient about this. Every day that this rolls on is actually a day of our lives which is affected by these long-term health conditions. So I think it's a case of maybe not being patient and actually translating some of this into actions. And we really look forward to helping you do that over the next couple of days. Thank you. Sorry.
I was going to do an introduction, but Annie's done a better one. Should you be the inpatient patient then? You should change it. You should change it. I will say a couple of things. We have been talking about the demographic inversion and the aging population for 50 years in this country. I've worked, believe it or not, for almost 40 in health here and in the US. And there's a lot of rhetoric that you mentioned, and we haven't really done a huge amount about it. I think we have now a critical challenge of the financial issue facing the National Health Service and social care. It is serious and real, and you need to just speak to anyone, as you know, at the Treasury, Department of Health, and government to realise the scale of it. And I think that offers us a lever and an opportunity to do something different that UCLP and the people that you're hearing this next 2 days will try to do. And finally, I think we have real involvement, as we've seen from the people who are with us today. And I think digital platforms and social media are going to help us as well. Now, we've got two great speakers. We have Jeremy Hughes, Chief Executive of the Alzheimer's Society, who's going to go first, and then Professor John Young from Yorkshire, Leeds and Bradford, and he's National Clinical Director for Integration and Frail Elderly. Do you like that title? You don't need to comment on that. But we're very lucky to have both of them. Jeremy might speak shorter length of time than John. We're going to have a discussion afterwards, beginning with our panels. So, Jeremy, I'll hand over to you.
Thank you, Pam, and thank you for the opportunity of being here. I just want to remind ourselves of the title of this session, which is An Ageing Population, an Opportunity. And I think it is really important that we remember it's an opportunity, and that people living longer is a good thing, and that we have an opportunity to make that life rich and wonderful and empowering for all those individuals and their families and the community around them. But having said that, let me take you to a place which is one of the wealthiest countries in the world, which probably has the best health service in the world, and yet take you to a group of diseases which are largely neglected, which fill 1 in 4 of our hospital beds, that cost the economy £23 billion a year, that by the end of this decade will affect 1 million people, and of whom only 43% of those people with those diseases get diagnosed. Because that's what we're talking about when we talk about dementia. That's the reality of dementia in 21st century National Health Service Britain. So we've got a large hill to climb, but I'm starting with that sense of opportunity. So what I want to do in the few minutes I have is give you some suggestions about what we can do in practical terms to make that difference. And why I'm really positive and enthusiastic about it is that we have a new system. It's very hard to change people's minds within an old system because everyone gets quite entrenched and they get stuck in what they're doing. But we do have a new system, as we all know. We've got clinical commissioning groups, we've got health and wellbeing boards, we've got public health moved into local authorities, we've got NHS England, we've got a whole new fabric of the way things work, not to mention academic health science networks, and the NHS IQ, the other bodies that have been set up alongside. It's quite confusing, and the King's Fund did a beautiful map recently to show us how confusing it is, but it is all new. And for something that's been neglected and forgotten, having that opportunity gives us a chance to get it right. Also, because dementia, Alzheimer's disease and the other forms of dementia have been largely neglected by the health and social care system and are costing us more than they need to achieve poor outcomes, which is where we are at the moment, because they've been neglected, it's often quite easy to put in place something new that hasn't been there before, rather than trying to unpick something that's quite entrenched and quite well established, where everyone has their parochialisms and their defensiveness. So that also makes me optimistic. The other thing that makes me optimistic is that we have a political commitment to doing something about dementia. We were very impressed last year when the Prime Minister made a speech on dementia. It's the first time a Prime Minister has ever made a speech on dementia in March of last year, and made dementia his personal challenge. Now, we're not quite sure within this room why he did that. We haven't found out whether there's any personal connection, and there often is. Many people know somebody with dementia. I don't think that's the case with the Prime Minister. He certainly hasn't declared it. Somebody said the reason he did it was because he went to a conference in France and Sarkozy had said he had made it his top challenge, and we didn't want to be outdone by the French. But I actually think the real reason is the thing I mentioned earlier, which is that it's costing the economy £23 billion, and the fact, as I mentioned again, that we're not actually servicing people with dementia very well by spending an awful lot of money not very sensibly. So I think that's probably what drove the Prime Minister, but it has made a big difference. It's very interesting. When I, as Chief Executive of the Alzheimer's Society, write to people saying I'd like to have a meeting, I get a few of them agreeing to a meeting. When the Prime Minister says, why don't we have a meeting, they all turn up. So it's been an enormous boost to have that leadership from the Prime Minister, and as we all know, the Secretary of State for Health also has made dementia a challenge, because I think he can see the chance to do something in the finite time he has before the next election to prove that the world can be a different place and that patients and people generally can get the support. And when I say people generally, I want to emphasise the importance of carers, because we know that across the system in England, there are over 600,000 people caring for people with dementia in a very unhelped way, a thankless task which leaves you physically and emotionally exhausted. It's all too sad that too often people move into nursing home or they stay in hospital longer than they need to because their carer is exhausted and can't cope, not necessarily because their own disease has got worse. So that's the backdrop of the opportunity. The final thing on opportunity, but I want to just put in before I give you some practical suggestions of what we can do, is around the wider society. Because I firmly believe that the way we tackle health and social care issues is not simply by addressing issues within health and social care. And actually, you know, we've got people in this room who can transform the health and social care world, and the pledges that we make at the end of this conference are absolutely fundamental, because if everyone here makes that commitment to do things differently, to talk to each other differently, that will change the health and social care world. But it's the rest of society that needs to play a part. And I'll come back to talking about the importance of dementia-friendly communities as the backdrop before I finish in a few minutes' time. Having said that, I must point out that the Business Design Centre is one of the least dementia-friendly environments I think I've ever been in. And I think we would all empathise with the fact that if you make something dementia-friendly with signage, it will probably help all of us as well. So let me just give you a few examples of what we can do, sort of next steps that will make a difference. And none of them are rocket science. And I'm a firm believer in quick wins. So these are my sort of half dozen or so things that we can do from this room, from today, to make things different. Firstly, we can diagnose people. 43% of people with dementia get a diagnosis. That means the majority of people don't. Now, if that was cancer, and I used to work in cancer as chief exec of Breakthrough Breast Cancer, if we'd had a situation that 60% or almost 60% of people with cancer died of their cancer before the disease was diagnosed, it would be all over the front page of the tabloids. We've somehow tolerated a situation where people don't get diagnosed. And we need a change of attitude. There's a very sad to say article in the BMJ a few weeks ago, and the headline of the article was "Political Drive to Screen for Pre-Dementia Not Evidence-Based and Ignores the Harms of Diagnosis," which is a series of untruths put together to make a big lie. And I would expect, as I'm sure Ed Miliband expects, a certain amount of journalistic interpretation in things like the Daily Mail, but I don't expect it in the BMJ. And what we have is a situation where nobody, absolutely nobody in this country is proposing screening for dementia. There's some academics researching whether we ought to look into whether it might be useful in the future, but nobody is proposing screening. But what we are proposing is that people with dementia should get diagnosed. It's not rocket science. 2 very senior GPs, and there are some doing fantastic work, I would hasten to add. There are some GPs showing the way forward and demonstrating it can work. And there'll be a riposte, I hope printed in the BMJ, to that article fairly soon, signed by many, many GPs who are outraged at this suggestion that you can't diagnose or you shouldn't diagnose. But 2 very senior GPs spoke to me with Alistair Burns, the National Clinical Director on dementia, not quite recently. And one of them said, "There's no point diagnosing people because nothing can be done," which was such a narrow medical interpretation. Yes, there's no cure. There are actually drugs that can alleviate the symptoms of Alzheimer's, and there are other things that can be done for other dementias. But the idea that you can't diagnose because nothing can be done ignores the empowerment of people through diagnosis and their families who can then manage their own lives. And the second thing was, they said, another of the GPs said, there's no point diagnosing because all that will do is worry people. as if somehow they were in blissful ignorance of the fact that their memory was playing up and they were having problems and that it would be worrying. So we have to tackle that. And we've just done, with NHS England, we've just published a book called The Dementia Guide. And the idea is that this is given to every single person when they get diagnosed, and it guides them. It sits on the bookshelf. It's a long paperback book. You keep it at home because the questions don't happen in the 10-minute consultation. They happen when you're at home the following night or the following day. And the idea is you have one of these and it helps you get the post-diagnostic support you need. So we need diagnosis and we need to empower people. It's one of the pillars of the house of care that Martin put up is information. We need to empower people and trust them with information. May I dare even say we could trust patients with their own records and to read about their own diagnosis in their own records. So diagnosis number one, information and empowerment to post-diagnostic support. Thirdly, putting in place that post-diagnostic support. So we've now got dementia advisors rolling out across the country. We are the navigators who help you. People, particularly people with dementia, particularly frail elderly more generally, need support. You can't assume that everyone will become an empowered patient or an empowered user of social care just by telling them. And that needs to be put in place. And then the next area I just want to highlight is hospitals. We've now got 143 acute hospitals signed up to becoming more dementia friendly. And we can do that. We've already got the This Is Me card that we've produced with the RCN. Again, it's not particularly difficult. It's something that you can have on the end of the bed that's been filled in by the person with dementia or their carer and explains who they are so that whatever shift of nurse or assistants coming in, they can get that support. So we can do more in hospitals. And then finally, I want to look at the wider community and the dementia-friendly communities and say, we can lead the way in supporting other people, and they're already doing it. So financial services are producing a charter on how to treat people with dementia and their carers in banks, building societies, insurance companies, so that if you can't remember a PIN number, you've got an alternative way to be part of society. You're not excluded and told you can't get your money when you want to get it. So dementia-friendly communities is the final bit that we can put in place, and we need to bring it back to the health service. We need to bring it back to our own fabric being dementia-friendly. Give you a very personal example. Where I live, where we've got a programme that's being led by a consortium of people to become a dementia-friendly community. So the local authority, the Women's Institute, the church, the voluntary sector, the bank, the supermarkets, they're all trying to become dementia-friendly. Well, I went to my GP practice, and it's just become dementia-unfriendly. So what you do is you walk in, and the receptionist who's never been particularly friendly, I must admit, is now behind a pane of glass. And in front of you, there's a keypad on the wall, and you have to put in your date of birth and your name to electronically register the fact that you've come to see the doctor. So a person with dementia falls at the first hurdle. So if we're going to create dementia-friendly communities, and it is a whole society response, let's start at home and get our own health service more dementia-friendly as well. Thank you very much.
Staggering over and back. John, please.
Right, I'll just see if we can get a slide up. Right, there we go. Well, good afternoon, everybody. I'm John, geriatrician. It used to be said I could talk about frailty for England. I now talk about frailty for NHS England. I'm sorry, it's a very poor joke, but just to lighten it a little bit. What I want to talk about is about frailty, and I know that's a bit of a turn-off. People are already now beginning to close down. But of course, frailty is one of those things, it might be the best possible outcome for most of us living our lifespan. So it's just something for you to think about as I go through this talk. I've got about 10 slides. I'm going to cut it down a little bit to make it slightly briefer. If there was a strap line to my talk, it would be around living better with frailty. Because that's what I'm trying to talk to. So first of all, just a tiny little bit of facts and figures that come from a national survey that was done last year around community services called intermediate care services. And you'll see the average age of the user of these services, quite old, 82. 77% had one or more long-term conditions, 41% had two or more long-term conditions. Nothing you think which is remarkable there, and of course, You know, that just talks to this agenda of the increasing number of people with multiple comorbidities. But just hang on, just a darn cock-picking minute, if you will. If there's 77% of people living with one long-term condition, that means there's 23% of people in this survey that were using community services that had no long-term condition. Okay? So that's a gift to anybody from the Daily Mail, if there's any Daily Mail reporters here. The strap headline's going to be a quarter of people receiving community care services to have nothing wrong with them at all. And of course that's not true, is it? Because we know that those of you who are healthcare professionals like myself, and everybody knows that that gap, that missing number are people with frailty. But this is the heart of the problem which I'm trying to put to you today. This is the frailty paradox, that although we know there's shed loads of frailty out there, because we don't code it or classify it, it's invisible. And it's invisible to the health and social care world in terms of proper healthcare planning and particularly proactive care planning. We all recognise it, but because there's no diagnostic process, it's an invisible condition, as I've just shown you there. And my thesis really this afternoon is very simple, that we need to find a way of identifying frailty in a much more proactive way, because what we know about frailty, and I'm going to show you this, is that it presents in crisis. Just in the same way, 20 years ago, people with diabetes presented with coma because it hadn't been diagnosed soon enough, and 10 years ago, people presented with really severe end-stage chronic heart failure because it hadn't been picked up earlier enough. So the same thing is now happening with frailty, and it has been happening for the last, well, since I've been a geriatrician, and it's not all my fault, I promise. But the issue is that frailty presents late and in crisis. So we need this earlier diagnosis of frailty. I'll just pass over this next slide for brevity, but just to give you a feel for the frailty side of things, so you can conceptualize it and engage with it, and then you can understand where I'm coming from in terms of diagnosis. This very simple little scheme just shows you about frailty in terms of loss of physiological reserve, loss of body function, very slowly over maybe 10 or 20 years. And I'll just do it on this side first of all, but here we've got functional abilities. So we're looking at the whole person, okay? Not a single system, looking at the whole person. And we're looking at them in terms of their functional abilities, in terms of independence and dependence. And here we've got a little dotted line, which is a theoretical line of decompensation. And you can see what I'm going to say is that gradually, over the aging years of your life, you gradually lose this magic thing called functional reserve, and you creep towards this line of decompensation. And here we've got an individual who's very close to the line of decompensation, but hasn't yet crossed it. So that person at the moment is fully independent, okay? You wouldn't know necessarily that they're frail at this stage. Well, I'm going to give you a top tip in a minute about how to identify them. But you wouldn't necessarily know in our current system that they're frail. But hey, what happens here is that they have something called a minor illness. In the jargon these days, we call it an ambulatory care condition, or ambulatory care sensitive condition, I should say. And here I've got a urinary infection. But equally, it could be an admission to hospital, which is a horrible event to a frail person because it exposes them to a very abnormal environment that can cause them to dip, and suddenly they decompensate, and it's like a switch. So it's a hyperacute, very rapid syndrome, like a switch. One moment they're independent, and an hour later they're dependent and unable to walk. And then hopefully they gradually recover, but maybe not fully recover. So here's, in a nutshell, this is what we're trying to do. Can we identify people close to the line of decompensation? Hey, that's really boring. Anybody can do that. That's not a challenge. The real challenge is, can we identify people with frailty much more upstream so that we can start thinking about frailty in the terminology of a long-term condition, and we can think about proactive care programs for these people. So I'm going to suggest to you that there are two possible ways of doing this upstream diagnosis, detection of frailty. And as an audience, I'm going to give you a choice. I don't know what you're going to choose, but I'm going to talk to two possible approaches for a more timely detection of frailty. The brave way, empowering the people to self-diagnose frailty, or the cautious way, empowering professionals like myself to tell you or tell people that they've got frailty. Which one shall we choose? Hands up who would like the brave way. Okay, well, that's just what I was expecting. But there is a consequence of this, and that's the pledge wall, okay? If you believe that this is what we should do, and I'll show you what I'm going to suggest in a minute. If you believe in this, then for goodness sake, go and sign a pledge to disseminate what I'm going to tell you in a minute or two back home in your own communities. This is your top tip. This is the way anybody, not a doctor, not a healthcare professional, the way any citizen can diagnose frailty, not at the very end of frailty, which is the way we tend to look at it in our health service at the moment, people decompensating with immobility, confusional states and falls, but long way upstream when they're just beginning the frailty process. And this is the 4-metre walk test. All you need to do is have 2 lines on the floor, 4 metres apart, and you need a stopwatch. Hands up who's got a stopwatch. Okay, hands up who's got an iPhone. An iPhone is an excellent stopwatch, so don't let not having a stopwatch put you off. And if people take more than 5 seconds to walk this 4 metres, it's a really reliable prediction of the fact that they're beginning to develop frailty. It predicts these adverse outcomes. There's shed loads of research evidence around this, and I don't want to this is a beautiful, beautiful slide, that's why I had to put it up. But I'm only going to make one point, which is just to say that these lines, coloured lines, represent different walking speeds over 4 metres. And here we've got mortality over here, and we've got age down here. So if we take the age of 75, what we see is there's a huge variation in walking speed from the healthy people at this end to the unhealthy, frail people down at the bottom here. And the simple point is that you can see that at the age of 75, there's a huge gradation in fitness. Frailty, if you invert frailty, it's fitness. So you've got people up here who are very fit, people down here who are very unfit. This is a fitness gap. And the really interesting question, which I'm posing to you, is what can we do for people who are down here at the low end of the fitness curve? Can we get them to move upwards to close this fitness gap? And the answer is we can, but it's all hinges on identifying these people down here in the first place. So the slower you walk, 5 minutes, okay, the slower you walk, the more frail you are. Really simple test. Take it back home with you, talk to people. I've got this vision where there might be a media event where we would promote this on television as posters in GPs, surgeries, in healthcare clinics, in social care clinics and so on. And we might encourage people to self-refer with frailty. Now, I know GPs in the audience won't like me saying that, but I think that could be a direction of travel that would be very profitable in terms of people living with frailty. So just to finish off, the more cautious way is a beautiful model of frailty that's called the cumulative deficits model, which is quite hard to say at this time of the afternoon. But basically it says the more things and the more smaller things which are wrong with you, the more likely you are to be frail. And it's a very simple index that can be put together that again has got shed loads of research underpinning it. A frailty index counts deficits. Deficits are little things which are wrong with you, symptoms, signs, diseases and disabilities. Maybe some of them are bigger than others. And the frailty index is simply calculating the proportion of a number of deficits which are present. So you can have a frailty index of 0, which is fully healthy, down to approaching 0.7, which is when the body is imminently about to decompose and sadly die. So we've been putting together a UK version of a frailty index. I'm really grateful to System 1, and I don't know if John Parry or Chris Bates is here in the audience. They've been helping us to do this. And this is a beautiful index because you have to do nothing new to calculate this index. This is all data that's held in electronic healthcare records at the moment. So we could produce this index right now, today, from existing electronic primary care-based healthcare records. And it gives you, I'll just pass on to the last one, it gives you a plot like this, where you have different levels of frailty index down here, from 0, which is fully fit, down to 0.7, which is pretty near to death. And you can see the distribution, and you can see instantly that these people here probably just need some general life advice. There's probably a group of people here that need, 2 minutes ago, that need some proactive case management and multidisciplinary team coordinated care. And there's probably some people down here that probably we should be having some discussions around end-of-life care. So I'm going to leave it there and suggest to you that my thesis to you this afternoon, fairly provocative one, is that frailty should become a positive diagnosis so that frailty can become a new long-term condition. And these are the advantages that that would bring. Thank you very much for listening to me.
Thank you, John and Jeremy. I hope I walked across there fast enough. We're running out of time a bit. Can I go on for 5? Yeah, good. We're going to go on a bit longer. Olivia's going to see if there's a response from our people's panel, and then we'll come back to you at the end. And in the meantime, if you want to ask a question, make a comment, could you stick your hand up sort of loudly? That'd be good.
So there was lots of nodding from the panel at the front, particularly when Jeremy was talking, I thought. But can I just say on the frailty thing, actually volunteers, communities, community resilience, people who are already doing this, how can we work with you to get some of those messages out there?
First thing I think we could do would be to popularise this very simple indication of frailty, this gait speed test, which is so simple to do and so well researched and underpinned by evidence. And I just feel it might give people a bit more confidence that, I mean, I see a lot of people in secondary care who come in after having a fall and they've lost their confidence, and you talk to their family and they say, Mum and Dad, they've been slowing up for a couple of years. That's literally the words they use. And you just think, for goodness sake, if we'd picked that up 2 years ago, we might not be where we are today. So I think there's just a message about trying to popularise that very simple approach for early detection.
So any panel members? We've got 2 of you. Penny, can we come to you at the very end? Is that okay?
Thank you. Fantastic, absolutely fantastic to hear both speakers. I said in my introduction, I also care for my parents. I'm a long-distance carer. I don't live with them, but my father has pre-dementia. He got it following a fall where he broke his hip. He is absolutely, he's basically now housebound because he's so scared to go anywhere because of what happened to him when he went into hospital. This is 3 years ago. He had a fall the other day on the 3rd anniversary of him going into hospital the first time because he was in such a state. Because, you know, and his healthcare team, for want of a better word, aren't, you know, he had no diagnosis. And in my day job as a self-management tutor and ambassador, when I'm recruiting people to come onto courses, you see people, you know, and your 4 meters in, however long it is just
5 seconds.
That's it, 5 seconds. It's fantastic because we're promoting and recruiting at events, and we're going up to people and saying, you know, do you live with a long-term health condition? And these people can hardly walk, and they know, oh, there's nothing wrong with me, dear. You know, and it's like, so if frailty actually did become a long-term condition, we could help people so much more.
Yeah. Well, it's encouraging to hear you say that. Thank you very much.
And it is, I think what's interesting is it's the basic awareness, not just amongst health professionals, but amongst the wider community, which is why we're doing the Dementia Friends programme, which is a base level of awareness. We want to get to 1 million people in the next couple of years, because then the neighbour is more alert to it, the shopkeeper is more alert to it, and they can then say to somebody, oh, maybe you ought to go and have that checked out. Maybe you ought to be encouraged to go and see a health professional.
Yeah.
Yes.
Yes. And I think we're both talking the same sort of language here around trying to give people the right tools so they can go and see their healthcare team in a way that gives them confidence to say, look, you know, I've done this test, it's not right. You know, let's have a conversation about what we can do.
John, you mentioned when you were speaking that it might not go down well with GPs. Is there a way, and I don't know whether GPs want to respond to that.
I hope nobody's recording that.
Doesn't add to the burden of identifying frailty earlier, because there were many nods out there. You can think about that if you like. There's some questions. There's one there.
Well, it was a comment on exactly that.
Could you say who you are?
I'm Simon Eaton from A Year of Care, and I'm a doctor in Northumbria. I think lovely talks. I think it's brave. It just isn't brave enough. You know, we're talking about self-diagnosis being brave, but what about self-treatment and self-management frailties as a long-term condition? And therefore, the community support, the peer support, not, oh, we'll send you to the doctor to sort you out. And then we're not promoting a dependency model. And it's exactly the same for dementia screening. You know, why is it not a normal thing for us to be is this a dodgy memory or not? Because, you know, yes, lots of doctors out there and they get, I'm a bit forgetful at times, and that gets a boring question. But, you know, I've done these things and I can give you something robust, and I've actually tried to start managing it. This is what's happening. Really different conversation. We're really getting somewhere.
And part of the house of care is bringing in the other professionals who can help with that joined-up approach. So to take two examples that we haven't talked about today is pharmacists, who often people see more than they do their doctor, and they go for the repeat prescriptions, and then physiotherapists who spend a long time with people and have conversations with them, much longer actually than the doctor ever spends with them. So how do we bring those professionals in as well to be conveying the same message?
John, do you have a response?
Well, yeah, I need to go and write something on the pledge wall, I think, because I think that the book that Julian's got here, the Dementia Guide, don't mind that. I think we need the frailty guide as well, actually. So my pledge, I think, is to try and see who I can get to sponsor. Obviously, I won't be able to get the Alzheimer's Society to sponsor it, but maybe Age UK, I don't know if there's anybody at Age UK here, or maybe indeed NHS England would sponsor a brief guide. A lot of these interventions, you're very correct, we shouldn't be looking at a medical model. It's things like making sure you've got your deafness sorted out, your spectacles, that you've got good footwear, that you've had your balance checked. Just simple things, nutrition, exercise. It's not rocket science, but these little things have got the potential to make a big difference and really ease the burden of urgent and emergency care, both in primary care and secondary care.
Yeah. Thank you. We have another.
Hi there. My name's Robin Grant. I'm a student at Middlesex doing mental health nursing. I didn't really know much about dementia, so I went to a conference in September at Birmingham University, and I learned a lot about dementia. We were told, correct me if all of you think I'm wrong, but this is what we're told, that only 47% of GPs have sufficient training in dementia management, a third are not confident in diagnosing dementia, 10% of GPs are only aware of the national dementia strategy. I was wondering, what are you doing? What do you think about how to address these issues?
Well, I'll give you a very quick answer is, and it's a more general point as well, because I think often you can demonstrate something around dementia that then cascades into other areas. My view, and I think the view of Alzheimer's Society, is we want the primary care, we want the GP practice to become the central point more for the diagnostics and support of people in their community. That doesn't mean every GP has to be an expert on dementia, but can't we bring the dementia specialists out of the clinic in the hospital, which is confusing for the person with dementia, has a 6-month waiting time to get there? Why can't we have those people moving and working alongside the GP in the GP's practice, bringing their professional skill, and then also, in the same time, they will be training up and educating their GP colleague? Because that's the way, I think it's a moving professionals together in the community location, rather than having them separated off and being shunted off to a hospital where you tell your story again because somehow the records haven't got there before you.
John, you have anything to add to that?
No.
Do we have any GPs, just before we close, do we have any GPs wanting to say anything? There, can we get back there? And then we'll come back to Penny and Sergey. Thank you.
Just on the point of diagnosis of dementia, in many cases, once you've made the diagnosis, there's a huge financial implication. And by that I mean things like social services, grants that you can get, money that can be paid to you. And in a number of areas that I know of, the only way that you can actually get those financial benefits afterwards is if you get a diagnosis from a consultant. And that, I think, is where a lot of the problem is. I would, if I could, make a plea that diagnosis should be able to be made by GPs just as effectively as by a consultant.
And we do have a few examples where people are, I shouldn't say this in this room, but there are a few examples where I know people are going against NICE guidelines and they're doing precisely that and it's working well. So let's evolve and it goes to the last question, let's support the empowerment and education and training in primary care, both by GPs and specialists coming into primary care to do it. But the cost, just to quickly, the cost of people with dementia going to hospital when they don't need to and staying there, which on average they do twice as long as other frail elderly, is much greater than the cost of actually supporting them in the community. And it's a bigger issue for this conference, but actually I'm sure a recurring theme is we have to find ways of moving money to where it can be used more effectively rather than leaving it siloed in the places where it always has been.
John, do you want to?
Only that I fully agree that in terms of frailty, at the moment, our health service is largely engaged with the manifestations of frailty, which are acute confusion, falls and immobility, and not doing any upstream preventative work. So there's a huge potential for us to disengage from all that emergency and acute care and to reinvest it in the community.
Thank you. We're going to close, I think, with Penny. Yeah.
Thank you. 2 points, really. First, this conference hasn't been going very long, but one recurring theme that's coming out is the biggest constraint to change is the funding structure, and that's got to change along with everything else. And secondly, I'd like to just say to Jeremy, I totally agree with the you're on the scrap heap because we can't cure your condition. And when I broke my neck, I was told that I couldn't have physiotherapy because they weren't going to be able to get me up and walking again, so there was no point. And I did have physiotherapy, and it's meant that I've stopped all the drugs I'm taking, I'm a lot fitter, I've cycled across 2 countries. It's just your general well-being and your general physical health. It's not about curing you, it's about quality of life.
One more, yes.
Yeah, hi. I just wanted to ask a quick question about, and I understand that what you've spoken about affects a particular group of people of a certain age. Just be interested to hear the work that you guys are doing around the other end of the spectrum, kids and children, and the education that they're getting, because I'm sure that a lot of those children will have been affected by both those conditions.
And it's a really good question, and we've actually got, it's just been reported, it will be announced later this month, there have been 21 pioneer schools taking education around dementia into the schools. And what we've found is a fantastic interest, and actually people are interested because their grandparents or even their great-grandparents have often got dementia, and sometimes they are the prime carers. So there is actually an interest and a willingness, and I'm absolutely with you, whether it's in schools and young people generally, or whether actually it's also in the training of the next generation of nurses and doctors. The long-term change comes about by changing people's attitudes and culture. And I'm a firm believer that actually if people want to work together, and it's the theme of this conference, if you want to work together, actually almost despite the structure, you can find ways of doing it. And that gives me hope and confidence that you can make things happen if you have the right attitude. And it does start, the younger you start, the better it is.
John, final word from you, if you have any.
Yeah, I mean, that's a very thought-provoking idea, actually, and I have to confess I haven't thought in those terms at all as yet. So I'm very grateful to the idea. I need to have a ponder about it, actually, and just see how we could mobilise different groups of people to help in terms of older people living with frailty.
Thank you. Can I thank John, Jeremy, Anya, all of you? But don't go away, but let's give them a round of applause. I have announcements about 2 of the working sessions. The agenda for delivering a positive patient experience, a self-care model, is going to be in workshop room A by the main entrance. And making information visible to enhance care for patients will be workshop B. Okay, so I think there are changes. And a marvellous announcement is that from now on it's free tea and coffee. Woo! I don't know what happened to your finances, but tea and coffee are now free. So thank you so much, and thanks to the panel.
Okay.
Do you want to take that?
Oh, I wouldn't mind, actually.
No, do.
Because I think